Hello everyone. Hello guys. I'm Dr. Kalyani and I am your pathology faculty at LearnElevate. I would rather like you to consider me as your friend who can simplify your life, your pathology life. This is the first live I'm going on this, going to do on this platform. And what we are going to do is that we are going to do a capsule revision. That is, I know that you're having exams soon, so we are going to divide. We have selected a few topics, that is like coming repeated topics and the most probable topics of pathology, and we have converted that to a capsule form. Let's see the questions. So there are 40 questions in total, and I am planning to do it like 20 today and 20 tomorrow. Let's start. So before starting the live, I would like to say, like, how I learned pathology is like I always learn pathology like a story, and I always want my students to learn it like a story because it's very interesting to learn if it's a story. Like we never forget a movie story, right, if it's interesting. But now as the exam is so near and we can't like go with the story thing now, so I have made this thing for you. Please make sure that you go before going to the exam, you read all these topics and be prepared well with your pathology. Okay, so I have divided the topics into two. That is, now we are having today as the basic day. So you know that as FMGE student, the basics are the most important thing that you guys have for exams. Today it's more of a basic day. That is, you know, what is the basic in pathology? That is the cellular adaptation, the injury, and the inflammation, all that stuff. Let's start the class now. So before going on to the main topics and the questions, I would like to tell you that just take a piece of paper and write down the most important things that I'm saying, or just screenshot the illustrations that I've created for you. Hope the illustrations help. Like, I am a visual learner because these illustrations and cartoons and all these images like stays in our mind. So I've created a few for you also, and few mnemonics also. So if you want that, you can screenshot and keep them so that you can just swipe and see before you go to the exam. Fine. So let's start with the question. So these are the topics that we are dealing with today. That is the cellular injury, adaptation, inflammation, neoplasia, and the hematopath and renal path we are having tomorrow also. Fine. So let's start. So the first question. See, the first question is. So I'm going to read the question. All are features of irreversible injury except. So we have the first topic, that is irreversible and reversible injury. So I'll be just saying a short version of what is this topic all about. So let's see. Yeah. We have, so before going into the topic, let me compare this thing with a real life thing. So take an example of a tire of a car. Okay, you're using this car every day. What happens to this tire? This tire is going to get a lot of wear and tear, right? So this wear and tear, what is going to happen with the tire? Using it every day on a rough terrain, the wear and tear will be there, but still the tire will be working fine. So that is what is happening to the tire when there is a change in the environment. Fine. So that adaptation that happens to the tire, that wear and tear that happens to the tire to adjust with the environment, that is called adaptation. That is the same thing that is happening to the cells in our body. For example, when you go to the gym and lift heavy weights, what happens? That we get a callus, right? So we are not going to break our skin, bleed or something, but we are going to get a hard layer of skin there. Why? Because there is a change in environment, there is friction, there is a large weight coming on the hand, and also there is going to be what? Callus formation, that is thickening of the skin. That is what is called as adaptation. So think of the tire again. This tire is going to be used again and again in many rough terrains. Then what is going to happen? There can be a chance of a puncture, right? But this puncture is an injury to the tire, but still this is reversible. You can stick the puncture and like carry on with that tire itself. That kind of an injury is called a reversible injury. That is, there is an injury that has happened, but we can switch that to normal and use it. That is reversible cell injury. Then what about the irreversible cell injury? Irreversible cell injury, think of this tire being used again and again, the whole tire is worn off. then you can't use the tire anymore. There is no going back. That is irreversible injury. So that is what is happening in the human body also, in this reversible and irreversible injury. Okay, let's see the reversible injury now. See what all that we see in the reversible cell injury is that, see in this you can see cellular swelling, fatty change and blebs formation. So what is this cellular swelling? You have always seen that whenever a cell is irritated, there is going to be a formation of vacuoles inside the cell. You have heard of that. Yes. So what happens when large vacuoles is formed inside the cell? There is obviously going to be cellular swelling. So when you look at it in a microscope, what you see is that there is cellular swelling. And when you see grossly, what you see, when take an organ, when each of the cell is swollen, what happens to that organ? The organ gets bigger. So there is organomegaly or organ swelling. That is what is happening in cellular swelling. And what is fatty change? Fatty change is that there is lipid vacuoles. The same vacuoles, the lipid vacuoles can also form. That is the fatty changes. And the blebs formation. See, think of a balloon. Like it's reversible, right? Even if you like put in the air, it is reversible. Like same to that, there is bleb formation. Because of what? Because of there is an irritation in the outer membrane, cell membrane. So there is bleb formation. That is mainly due to the cytoskeletal changes. Okay. Cytoskeletal changes, this blood formation happens. So, and now we have the irreversible injury. See, the irreversible injury, we are having pycnosis, karyolysis and densities in mitochondria. What is that? This pycnosis, you can see in the image that, what there is the nucleus of the cell is shrunken. That is called pycnosis. And in karyolysis, what is karyo? Karyo means nucleus. So karyolysis means what? There is breakage. So karyolysis means there is breakage of nucleus and densities in the mitochondria. These things are irreversible cell injury. What happens if the center is ruined? The center is in nucleus, right? If the center is ruined, the entire cell is gone. That is what is happening in irreversible cell injury. So just imagine like this pycnosis, karyolysis and all is like kind of tough words. So that goes with irreversible. That is not reversible. So that is a irreversible and reversible injury. So hope you understood that. So what was the question? The question was all other features of irreversible injury except what? This pycnotic nucleus is irreversible, as you have seen. Karyolysis and densities, both these three are irreversible. So blood formation is the answer. That is reversible. All right. That is the first question. So next, let's see the second question. So the second question is, let me read the second question. It is a dystrophic calcification is seen in. Okay, so let's understand this. What is this calcification? Then we can answer the question. Okay, so say we have an image here. You can take a screenshot if you want. Yeah. Yeah, so in this we have dystrophic calcification and metastatic calcification. Fine. So how I learned is that the dystrophic calcification is DD, that is in the dead tissue. The calcium deposits happens in the dead tissue. Because imagine it as like remember it as D, and then here also there is D. And see, when there is a local injury, there is going to be what? If the necrosis is happening, there is going to be deposition of calcium. So is there any chance that there is an increase in calcium level in the blood? No. So the calcium level in the blood will be normal, and the cause can be very old abscesses and old injuries, and it is always localized. For example, the gone focus. You all know what is a gone focus. It is present in the primary tuberculosis. And what is metastatic calcification? Metastatic calcification is that the tissue is healthy, but there is a high calcium level in the blood. So what is going to happen? This calcium is going to deposit in the tissue. That is what is happening in where? Hyperparathyroidism, because parathormone increases the calcium level in the blood. So when there is hyperparathyroidism, the calcium level is going to increase in the blood. And if what happens if the bone destruction goes on, the calcium is going to get released into the blood, and this is going to deposit on the tissue. That is called metastatic calcification. All right. So So yeah. So let's see the question once more. Dystrophic calcification is seen in hyperparathyroidism? No, it's metastatic. Atherosclerosis, let it wait there. Vitamin D disorders? No. These both, the A and C are both metastatic. And this lymphoreticular malignancy is a group of lymphomas. So the answer is atherosclerosis, because atherosclerosis is a local injury, right, to the vessel, inside the vessel. So that is the answer, atherosclerosis. Now let's go on to question number 3. Yeah. So the question number 3 is, what is the location of lactate dehydrogenase inside the cell? So let's understand what this lactate dehydrogenase is. So we know that this lactate is converted to pyruvate by lactate dehydrogenase enzyme for release of energy. It is present in almost all the cells, right? So what happens? This lactate dehydrogenase is present in the cytoplasm of the cell. So when it is present in the cytoplasm of the cell, what happens? When there is an injury, the cell is going to break and this lactate dehydrogenase is going to get released into the blood, right? So what is this lactate dehydrogenase? It acts as a marker. Because why? Because it is getting released, so we can know that there is a cell injury, right? So we have here in lactate dehydrogenase, there are 4 important lactate dehydrogenase you have to remember about. That is the lactate dehydrogenase 1, that is present in the myocardial infarction. Whenever there a person we suspect myocardial infarction, if we look for LDH, it will be positive, LDH1. And next is LDH2, that is seen in blood disorders like hemolytic anemia, and LDH3 and LDH5 are there, and LDH3 is seen in platelets and platelets disorders like mainly in the pulmonary embolism, and 5 is seen in muscular dystrophy. That you have to keep in mind. And the main thing is LDH is present in the cytoplasm of the cell. All right. Next is question 4. Okay, let me read the question. An 83-year-old man shows presence of perinuclear pigment in the cardiac muscle fibers. What is the nature of the pigment? Okay, so what does this perinuclear means? Perinuclear means it is around the nucleus. Okay, so there is around the nucleus some kind of pigment in the cardiac muscle fiber. This is an elderly person. So what is the nature of that pigment is asked. So see, here we have this hemosiderin. What is this hemosiderin? That is a iron pigment. When hemolysis happens, what happens that when hemoglobin is broken down, there is a pigment generated, that is hemosiderin. And melanin and iron, that is not going to come in cardiac muscles. So the answer is lipofuscin. What is lipofuscin? Lipofuscin is that it is a wear and tear pigment. So you know that an 83-year-old man with some cardiac issues is going to get a wear and tear in his cardiac muscles. So this compound is found. Then how is it formed? It is composed of polymers of lipids and phospholipids complex with protein. Okay, so what does this mean? If there is lipofuscin pigment there, then it means that it is a sign of free radical injury and lipid peroxidation. Okay, so we can see these in the heart patients and the patients with chronic liver diseases and all that stuffs. So this is a very important topic, lipofuscin, that is a wear and tear pigment. Okay. Next is question number 5. Question number 5 is, which among the following ions is important in cell injury? So yeah, the answer to this question, as you all know, is calcium. Because why? We have already learned about the dystrophic and metastatic calcification. Whenever there is injury, the calcium is always deposited. For example, fat necrosis. You have seen that whenever there is fat necrosis, like in pancreatitis or in the breast tissue, you can see what calcium is getting deposited. So the main ion that is involved in cell injury is calcium. So what does it mean when there is calcium deposition? Yeah, calcium deposition means there is a irreversible form of cell damage, that is because there is accumulation of calcium in the mitochondria. Fine. So that is the answer. And next is the liquefactive necrosis is seen in which of the following? So the options are kidney, heart, cerebrum, and intestine. So before going to this, let's see what this necrosis is all about. Okay. Yeah. So I have created an image for you. You can take a screenshot if you want. Yeah. So what is this necrosis? Necrosis means there is tissue death. The cell death has happened. Why? How is this cell death happening? When a cell is working properly means it has all the environment that is needed for it to work properly, like the nutrients, the blood supply, and there is no toxins, and all the environment is clean and good, right? But if there is an injury, if there is an infection, if there is an ischemia, or if there is a decreased nutrient supply or blood supply or anything like that, then this is going to cause inflammation, and this will subsequently lead to cell death or necrosis. So there are 6 important types of necrosis, and the first one is coagulative necrosis. So what is this coagulative necrosis? This coagulative necrosis is commonly caused by hypoxia. Okay, commonly caused by hypoxia, and the main thing you have to keep in mind is that this coagulative necrosis is always like there is a dead center and a living periphery. Okay, it will be always surrounded by a living periphery. Like for example, in the heart attack, in myocardial infarction, a part of the tissue is dead and all the surrounding tissues are alive. That is what is happening in a coagulative necrosis. And second one is liquefactive necrosis. So what is liquefactive necrosis? The dead cells are going to dissolve into a liquid. That is, so when I went to the when we had that post-mortem thing we go on with when we are doing the MBBS, right? When we went there, we had a body, and this body was like it was there for 3-4 days inside a boat. No one knew that that person was dead and there, and it was all putrefied, the body. And when we took out the brain, it was like simply it was like it just like melted. That kind of thing that happens with brain. So liquefactive necrosis is always with the brain. So our question was about liquefactive necrosis, then, and that happens with cerebrum. Okay, liquefactive necrosis always happens with cerebrum. Okay, and the third is caseous necrosis. Caseous is, remember it as CC. That is, caseous necrosis is cheese-like. It is friable and cheese-like, and most importantly, it is seen in tuberculosis granulomas. That is very common. Everyone knows about that. So you have to keep that in mind. Remember it as CC, cheese and caseous. Okay. And next is fourth is the fat necrosis. What is fat necrosis? Fat necrosis is like there is chalky white deposits on the fat. What was that chalky white deposit? It is mostly calcium. That is fat necrosis. Where do we see that? We see in acute pancreatitis, in breast trauma, we see this fat necrosis. You can see the image here. If you can just have this visual memory, you can easily recollect these. And next, fifth one is the fibroid necrosis. What is fibroid? When you hear the word fibrin, what comes to your mind is blood, right? Yeah. So obviously this happens in the blood vessel, where in vasculitis and autoimmune diseases, this happens in the blood vessels. See, the picture is there. And the sixth one is the gangrenous necrosis. That is the clinical term that we use for necrosis in extremities, like in the fingers, in the feet and all. We use this gangrenous necrosis, and the examples are lower limb ischemia and frostbite. Okay, just learn this. You'll get to answer almost all the questions. Okay, fine. Next, let's go on to the 7th question. So this is P53 regulates which phase of cell cycle? So this is interesting because cell cycle, yeah, here we have the cell cycle. So yeah, you know that this M is the mitotic phase, and all the G1, S and G2 is the interphase, what is called the interphase, right? So G is commonly referring to grow, and S is referring to synthesis. So G1, there is growing, there is production of protein and all, and S is where there is DNA synthesis is happening. And you can see there this yellow thing here, and also here we can see that yellow thing. That is a resting stage. That is a stage where there is a time, like there is a break for the cycle to check whether there is any DNA damage. Okay. So the question is, where is the role of P53 in this gene? So what is this P53? This P53 is called the guardian of the genome. Genome, as you know, is our entire DNA thing, and this P53 is the guardian of the genome. That means P53, it is a tumor suppressor gene. Okay, it checks whether the DNA replicated, the DNA formed is right, or is there any mistake in the is there any DNA damage that is happening. Okay, that is what P53 is doing. So what happens is that if there is in G1, yes, this P53 is acting. That is because just before the DNA synthesis is happening, the P53 becomes active. So when it becomes active, if the DNA that is formed is intact, it is very good. There is no error. Then P53 is not active; it is inactive. If there is any DNA damage that is happening, then the P53 gets active. So what happens when this P53 gets activated is that the P53 there is increased P53. So what happens when there is increased P53? Increased P21. So when there is increased P21, what happens is that it inhibits CDK cyclases. Okay, CDK cyclin complexes. What is the CDK cyclin complexes? These are the one that pushes like the cells from one cell cycle from one cell cycle stage to the next cell cycle stage. That is what is the CDK doing. Okay, so this CDK, and what happens when this CDK is inhibited by this increased P21, this RB protein, that is retinoblastoma protein, is going to remain active. When RB protein remains active, what happens? Cell cycle will get arrested. So there is stopping of cell cycle. So what happens? The P53 has blocked this wrong damage, like the DNA damage. It blocked the DNA damage. That is what this P53 thing is doing. So it is called the guardian of the genome. It guards, and it will not let any error happen in the system. So what if this P53 is not there? Then there is going to be chances of tumor, because there is no one to check. So yeah, and next, let's see the next question. Okay, next is the question number 8. Question number 8 is pro-apoptotic gene and anti-apoptotic gene belong to which gene family? So you know what apoptosis is, right? Apoptosis is programmed cell death. So that is what is needed for the proper functioning of the system, that is inbuilt within our system. So the question is, what are the pro-apoptotic? From the word you know that pro-apoptotic means that is favoring cell death, programmed cell death. And what is anti-apoptotic? That is not favoring cell death. So how I remember this thing is that, see, the answer is here, but see this anti-apoptotic bodies, anti-apoptotic and pro-apoptotic. This pro-apoptotic bodies, they favor cell death, right? So they are bad boys. So who are bad? BIM and BID. See, BIM and BID are bad. They what induces cell death. That is how I remember this. BIM, bad, and BID. That are the pro-apoptotic bodies, and anti-apoptotic bodies are BCL2, BCLX, and MCL1. So how do I remember this is that, you know BLS, right? Basic life support. Yeah, that BLS is life saving. So this is also anti-apoptotic. It is not causing cell death. It is against cell death. So this BLS and BCL is a little bit similar. So you can remember like that. I used to remember like that. So anti-apoptotic bodies are BCL2, BCLX, and MCL1. Okay. Okay. That's all about. So the question was, which belongs to which gene family it is asked. It belongs to the BCL gene family. Okay, P53 we have already discussed, it's not that. And BRAF is a proto-oncogene, and RB, you know, it is retinoblastoma. That has no role in this, so it is BCL. Fine. So the next question is, in individuals who donate one lobe of liver for transplantation, the remaining organ soon grows back to its original size. This is an example of which type of adaptive mechanism? So I have already told the whole story of adaptation, cellular adaptation to you now. So let me tell you another story. See, I used to always learn it like this way. See, imagine there is a biscuit factory near to your house. There is a big biscuit factory. So what happens with this biscuit factory is that everyone likes this biscuit. So what is going to happen? The sales are going to surge. There is an increased demand, and also all sort of thing is going to happen. So, when that is happening, what happens? The administration of the biscuit company is going to decide, okay, wait, the sales are going very up, so let's hire more workers, right? You see the second picture here. They're hiring more workers, so more sales, more demand, more. What is happening? More workers. That is, when there is more usage, when there is more demand, more number of cells. That is one kind of adaptation that factory is doing. Fine. Okay. If think there is no, they are not planning to hire any workers. They are going to use the workers already there in the factory, so that it can they're not planning to hire anyone else. The ones there is enough. So what is happening to the people there in the factory? They're going to lift heavy, they're going to work hard, they're going to work a lot there, right? Because the sales are very, very high. So what happens? They're going to get a we get very strong with big muscle. See this guy here, he's having a very big muscle. Yeah, so the cell is going to increase in size. That is the next kind of adaptation. So if there is increase in number of cells, that is many workers, hyperplasia. If there is, see this, if there is increase in size, see that muscular person there, yeah, if there is increase in size, then it is hypertrophy. And okay, and all of a sudden, say the story goes like this. The biscuit company is the sales are going down, people are saying it's not good, it's some kind of thing is added and all. What is going to happen to the company? It is going to shut down. See the company, the third image, it is shut down, the paint has gone, it has shrunken, the company is shrunken, right? The sales got shrunken. So what is that? That is atrophy. When there is disuse, when there is no use, when there is no supply of money, that with no supply of blood, what happens? The cells shrink. That is atrophy. And so what is now the factories administration going to do? When they just did a very good research, they came to know that everyone is so health conscious, so they are converting their business company, this biscuit company, into a protein powder company. So see, they have converted it into a protein powder company. That is from one cell type to another cell type for better adaptation, right? That is called metaplasia. That is how the cellular adaptation story goes. So here we have the original cellular adaptation diagram. So you can see here the normal cells. So there is a cellular stress in this, and see, there is change, that is change in size, that is called atrophy. And there is what change in size? Decreased cell size. And here there is increased cell size, that is hypertrophy, increased number of cells, that is hyperplasia. And here, what is this? Protein company, that is metaplasia, type of cell, from one mature cell type to another adult mature cell type. And dysplasia is abnormal cell growth. Okay, that is a precursor of carcinoma. So fine, the question was, what was the question now? That is the liver transplantation. So liver transplantation, what is going to happen? Obviously it is hyperplasia. The number of cells are going to increase. It's not the size of the cell, it is the number of the cells. So the answer is hyperplasia. Fine. So that is about our factory and the gym guy. So next is question number 10. Question number 10, a reversible change occurring in which mature cell type is replaced by another mature type. Just now we told this, that answer is metaplasia. So see, I've created an illustration for you. See, so how is this metaplasia happening? It's not just cell proliferation or something. It's transdifferentiation. Okay, remember this term, transdifferentiation. So what is happening is that there is genetic reprogramming. So because you see, when there is squamous epithelium, the genes are coded in such a way that there it has to be squamous epithelium. So if the squamous epithelium is about to be converted to columnar, means there has to be a genetic reprogramming, right? So this genetic reprogramming is called transdifferentiation, and this transdifferentiation, a new mature cell type is formed. See, this is the squamous epithelium. That is what is happening in metaplasia. Remember this term, transdifferentiation. You can screenshot this and keep it in your phone. And the most important type of metaplasia is the Barrett's esophagus. This is very important question. Most of the examiner's favorite maybe. Yeah. So what happens here? When you eat so much of junk like how we do now, you are going to get a chronic acid reflux. So when this acid reflux keeps on happening, what is going to happen is that the poor squamous cell, where they are very thin, these squamous cells cannot afford this. So they have to transdifferentiate. There is metaplasia going on, and that is going to get converted into metaplastic columnar epithelium so that they can tolerate this acid reflux. Okay, that is Barrett's esophagus, and this is a precursor of esophageal carcinoma. So keep this in mind also, from squamous to metastatic columnar epithelium. Fine. That is about Barrett's esophagus. So next is question number 11. So question number 11, let's read. Councilman bodies are formed due to process of dash. Okay. So what is this councilman body and what is all these things written down there? Let's see. So here the first option was necrosis. You all know what necrosis is. It is a cell death. Cell death is due to what? Injury. But if it is programmed, then it's apoptosis. When it is due to an injury and inflammation, it is necrosis. So, and what is cirrhosis? You know, it is an irreversible liver disease that is caused, that where the healthy tissue is goes on with its fibrosis and regenerative nodules. And what is this necroptosis? This is actually an apoptosis, but there is inflammation along with that. That is called necroptosis. Actually, necrosis and apoptosis joint kind of thing. Okay, that is normally this is inflammatory, and the difference is that apoptosis is always carried on, executed by caspases, as you know, right? So but this necroptosis, there is no like mediation with this caspases. So, necroptosis, you have to remember, there is inflammation, and apoptosis, there is no inflammation. Fine. So what is this councilman bodies? Councilman bodies is seen in the liver. When there is an injury to the liver tissue, what happens is that, what happens when there is an injury? There is breakage of the cytoplasm, the membrane, the nucleus, and what happens? The cells shrink. And when the cells shrink, there is going to be an eosinophilic apoptotic body. Okay, so councilman bodies are eosinophilic apoptotic bodies that is found in the liver. I'll show you. See, this is a councilman body. You can see an eosinophilic apoptotic. See the nucleus, it's shrunken, right? Yeah, that is councilman body. So the question was, councilman bodies are formed due to the process of what? It is a eosinophilic apoptotic body, right? So it is caused by apoptosis. Okay. So hope you understood that. It's easy, right? Councilman body. Okay. Next is question number 12. Which of the following helps in cell-to-cell adhesion? Okay, that is very basic. You should know the answer. The answer is E-cadherin. So what is this E-cadherin? Yeah. So when there is two cells, these cells are always close to each other, right? Yeah. So when they're close to each other, there is something in between them that keeps them together, and that also lets them communicate. So it's kind of like love, right? When there is two people loving each other, what like connects them is the love. That this love is E-cadherin. Okay, remember like that. E-cadherin is love between the cells. They are glued together, and these are the surface molecules that provides the closeness together, and they transfer the signals between one cell to the other. So what happens when there is tumor? This E-cadherin function will be lost because there is proliferation, breakup. Yeah, fine. So the answer, what is the so which one of the following helps in cell-to-cell adhesion is E-cadherin. And you can see the other options here, that is interleukins, interferons. These are all you know, right? These are all cytokines by the leukocytes, and interferons are mainly linked with viral diseases. And what is matrix metalloproteins? They are actually proteolytic enzymes that depends on zinc. These play a very important role in tissue remodeling, and it is found in extracellular membrane. Okay, this matrix metallic protein is. You have to remember what E-cadherin is. That is very important. Fine. So that is about E-cadherin. And next, again, our favorite topic, cellular adaptation. What is the question? So let's read the question number 13. A patient who was previously with good muscle mass now presents with decreased muscle mass. There is history of RTA, road traffic accident, which led him to be bedridden for 6 months. This decrease in muscle mass is best explained by. So what are we saying here? We are saying there is disuse of a muscle, right? That person is bedridden, he's not walking, he's not using his muscles. So what happened to the factory that was not used? It got shrunken. So what is happening here is atrophy, right? Easy question. So I have given here another image. See, these are the causes of atrophy. You can see, yeah. So what are the causes of atrophy? Here you can see decreased workload. See, same image is given here, that is bed rest and immobilization happens. There is no workload for the muscles. So what happens? There is disuse and there is atrophy. Or if there is loss of innervation. When there is denervation, what happens? No signals are sent to the muscles and the muscle is going to be weak. So that is going to cause atrophy. And next, what is the third thing? Decreased blood supply. When the blood supply decreases, obviously the nutrient supply, oxygen supply, everything is decreased. So that is going to cause ischemia and atrophy. And what? Inadequate nutrition. Then aging. So obviously you have seen your grandparents and all, they will be losing all the muscle masses, right? Their hands and legs will become lean. Why? Because of aging. This aging can cause atrophy. And endocrine causes, okay? Like what happens when there is menopause to the females, they will be having osteoporosis. That is a kind of atrophy, right? Because there is no estrogen. That is, so these are the causes of atrophy. You can capture this picture. Fine. So let's go on to the 14th question. So the 14th question is, a pregnant uterus is an example of. Okay. So the pregnant this is a very simple question, right? See, metaplasia, no. Dysplasia, never. Atrophy, is it? You have seen the stomach of a pregnant lady, right? No. So what is it? It is hypertrophy. Just remember that our dude with the big muscles. Yeah, that is pregnant uterus. See, the answer is hypertrophy. All right. And I have to add one more point here, is that there is something called pure hypertrophy. What is pure hypertrophy? Because some cells in a body, like for example, take the breast during the puberty. What happens? The breast development happens, right, in females. But in that, hyperplasia and hypertrophy is taking place. Both are taking place together. But in some cells, only hypertrophy takes place. That is called pure hypertrophy. Okay, which all muscles? The smooth muscles and cardiac muscles, there is only hypertrophy. That is pure hypertrophy. Why? Because they do not have a stem cell pool. Okay, they do not have a stem cell pool, so there is no hyperplasia, there is only hypertrophy. So in this uterus also, it's smooth muscles, so it is hypertrophy. Fine. Hope you got the concept. That's all we can do in a capsule thing. Okay, we'll go in detail in the coming up sessions. Now we have to go like this. So the next question is question number 50. Oh, this is what we have already told, apoptosis. What is apoptosis? You don't have to look at the options. You can say it is internally controlled and it is programmed cell death. Yes. So what is the answer? Internally controlled and programmed cell death. See, externally controlled, no. Internally controlled, programmed enzyme degradation, no. It's not enzyme degradation. It is cell death. And here also it will see, this option will confuse you. Programmed karyolysis. It's not just karyolysis, no. The entire cell death is happening. So it more apt is programmed cell death. So internally controlled programmed cell death. That is what apoptosis is. Fine. You can see here. So I have given a few features of apoptosis also here. That is the salient features of apoptosis here. There is no inflammation, because this is programmed. Our system is not going to program an inflammation, right? We never do that to a body. Our system won't do that to a body. It is made like that. So there is no inflammation and there is cell cell shrinkage, and there is formation of apoptotic bodies. So we have learned another apoptotic body just now. What was that? That was Councilman bodies. Okay, that is what is about apoptosis. And you have to, what we have to remember in apoptosis is that the main what executes apoptosis is caspases. Okay, caspases. Let me write it here. Caspases is what is so, and there are two pathways. Okay, internal and external pathway. So this internal, external, or intrinsic or extrinsic pathway, and this intrinsic pathway and extrinsic pathway. In this intrinsic pathway, what happens is that if there is any DNA damage or there is stress to ER, that is endoplasmic reticulum, this intrinsic thing gets activated, and this extrinsic is by any external factors. Okay, so this is mediated mainly by the BCL, BAX and BAK. Okay, and in the extrinsic is mediated by FAS and TNF alpha. Okay, just keep this in mind, and also caspases, very important. And where was not caspases involved? It was necroptosis. Fine. And now we have the 16th question. Okay, question number 16. Chronic inflammatory mediator. So this is a very important topic. You have to anyways learn this thing. Okay, never go to your exam hall without learning this table. See, I have made a table here. I don't know why this thing is zooming in. Okay, fine. See, there is this table shows there's features, acute inflammation, chronic inflammation. Just remember like this way, this IL, this all seems like one, right? So acute is like happening first, chronic is long time. So remember it like that. IL is always acute. All looks like one, right? This I, yeah, remember like that something. I used to remember like that something. You also do something like that, and you can't help otherwise. This you have to learn. So acute inflammation is IL-1, IL-6 and TNF alpha, and chronic inflammation is TGF beta and IFN gamma, the interferon gamma. This the mnemonic I used to remember is very funny. See, this chronic inflammation, I used to say chronic means what? For a long period of time, big time, right? So KGF, I used to remember KGF, okay, and TGF, like that I used to remember. You can remember whatever way you want. Anyways, TGF beta and IFN gamma, that's interferon gamma, are chronic inflammatory mediators, and acute is IL-1, IL-6 and TNF alpha. Okay, you don't have to learn all these things, but just remember these names, okay, the mediator's name, that is very important. So what was the question? The question was chronic inflammatory mediator, that is IL-1, IL-6, TNF alpha, TGF beta. What is that? What is that? This is acute, this is acute, this is acute, and this is chronic, TGF beta. All right, so that is chronic inflammatory mediator. Fine. And this is another thing that if you want, you can remember. This is good. Like if you get the clinical scenarios with these values, you can easily spot if you know this. So what happens when you get an infection? You get fever first, right? So if you get in fever first, what is that? First IL-1, right? That is fever. Then after that, what you do? You go to the hospital and check the CRP. That is IL-6 is CRP. And TNF alpha is acute inflammation and shock. And what is interferon? Interferon is macrophage activation. That is chronic. Okay, interferon gamma is chronic and macrophage activation. And TGF beta is what? Chronic inflammation with fibrosis. So just learn this. It can help you with the clinical scenarios also. Fine. So that is with the chronic inflammatory markers. And now we have question number 17. So let's read the question. Child presents with hematuria. Okay, there is 20 RBCs, RBC cast and edema. There was evidence of deranged RFT as well. So what is the problem? This is renal patho. So let's see. So the answer to this question is PSGN, that is post-streptococcal glomerulonephritis. So before we discuss this question, let's discuss the next question, and after that we can come back to this. Fine? Yeah. So read this question. I'll read this question. Question number 18. A 5-year-old boy presented with periorbital edema as well as ascites. Upon electron microscopy, effacement of podocyte was seen. So this is the question. So we have here the minimal change disease, FSGS, IgA nephropathy, and nephrotic syndrome. Let's see all these in just like short forms. Okay. So first is the minimal change disease. So what is this minimal change disease? So why is it called minimal changes? You know what is podocyte? Podocyte is something that is seen like, yeah, this is something how the podocyte looks, okay? And this is found along with the glomerular basement membrane. This supports the glomerular basement membranes, and this is called the food process of the podocyte. So what happens in this minimal change disease is that this food process gets destroyed. So what happened? This acts as a barrier for not letting the proteins come out through the urine. Okay, it will not get filtered out. So what happens if the food process is not there? If it is not there, then the proteins are going to come out. Not only proteins, lipids are even going to come out from this. So that is called minimal change disease. Why is it called minimal? Is that in normal glomeruli, when we see on light microscopy, it will be normal. There will be no problem with the glomeruli seen. But if we go look in the electron microscope, we can see this damage to the podocyte. So that is minimal damage. That is why it is called minimal change disease. Okay. So that is what is about minimal change disease. So what was the question there? The question was a 5-year-old boy. This is commonly seen in children also. Okay, so there is a 5-year-old boy with periorbital edema as well as ascites. And what is that? The effacement of podocyte. This effacement of podocyte is a classical sign of minimal change disease. So the answer is minimal change disease. So let's not go without discussing all the other three. Let's just see what all these are. Okay. So I have here, we have this nephrotic syndrome and nephritic syndrome. You know that, right? So just remember this can help you. See, nephrotic syndrome is what happens in nephrotic syndrome is protein loss, okay? And nephritic syndrome is inflammatory. Like I remember it as nephritic, it has a I, so it is inflammatory, and nephrotic as a O, so it is protein. That is how I remember this. So you can also remember like that. So nephrotic syndrome is protein loss. What happens? The podocyte get damaged, the protein is lost through the urine, and there is a loss of negative charge of GBM. That means the protein is going to be filtered out, and we are going to lose a massive amount of protein from the blood. That is what is happening in nephrotic syndrome. And what is nephritic syndrome? It is inflammatory, immune mediated glomerular inflammation. There is inflammation of the glomerulus. Why? Because there is immune mediated deposits on the glomerulus, and this is going to damage the membrane, and there is inflammation capillary rupture. What happens when there is inflammation? Obviously there will be capillary rupture, and when there is capillary rupture, then there is going to be blood. So there is both protein and RBC, that is proteinuria is also there and hematuria is also there. So that is what is happening in nephritic syndrome. Okay, this is a must know, very important. And next, so what all are the diseases that is coming under nephrotic and nephritic is given here. So just remember like this, all the pathies, okay, nephropathies comes under nephrotic, that and minimal change also. So here we have, and also FSGS. FSGS is focal segmental glomerulosclerosis, and membranous nephropathy, diabetic nephropathy, and amyloidosis. You know that. These all come under nephrotic syndrome. And in nephritic syndrome, what is there is post-streptococcal glomerulonephritis, IgA, lupus, and rapid progressive vasculitis. These are under the nephritic. You have to know this. There is no skipping, okay? And this is another mnemonic I have created for you, that is nephritic imagine it as, remember hurts. This nephritic is going to hurt you. That is what H for hematuria, U for urine is decreased. That is oliguria. R, there is RBC cast. T is the tension is increased. That is BP is increased. And S is swollen glomerulus. That is inflammation in the glomerulus. So hurts for nephritic syndrome. And for nephrotic, remember peels. Okay, protein, right? So P, peels. What is peels? There is protein loss. And E, edema. And next is there is decreased effective albumin, that is in albumin in our blood is decreased. And L is lipid and fatty cast. So obviously when lipid is lost, what happened? What is going to happen? There is fatty cast in the urine. So this is how you can remember nephritic and nephrotic. Okay, note it down in your notebooks so it can help. So let's go back to a question. So what was the question? This we have discussed. The previous question was child presents with hematuria. So child, first clue, second clue is hematuria, and there is RBC cast. So see, there is RBC cast and hematuria means it is definitely nephritic, not nephrotic. So it is not FSGS. FSGS is nephrotic, right? And MCD, what minimal changes, is also nephrotic. And next is what? PSGN and IgA nephropathy. This is not going to be IgA nephropathy. This is going to be what? It is nephritis for sure because there is hematuria. So it is post-streptococcal glomerulonephritis. And this is common in children. In children with 1 to 3 weeks after a throat infection. You know that, right? When the streptococcus causes a throat infection, that is going to further develop into other complications. And one of the complications is post-streptococcal glomerulonephritis. Okay, this is a classic example. Just see all this. Fine. And next is there is question number 19. Okay, this is the second last question we are going to do today. So yeah, this is rolling of leukocytes on endothelial cell is mediated by what? So let's see just the inflammation thing in just a short. See this image. Yeah. So what happens when there is an injury to the blood vessel, or if then there is an injury to a skin, what happens is that the blood vessel under it, the blood will be moving. What suddenly happens when there is an injury is that first thing that is going to happen is margination. Okay, margination is the thing that is going to happen. That is the leukocytes that is floating everywhere in the blood is going to come to the margin. Like this, see, it is migrating to the margin. This process is called margination. Okay, margination, and this is mediated by what? See here, see margination. This please take a screenshot of this also. Okay, this can help you. And margination, see, margination is happening, and after that what happens is that this is going to roll over the surface of the blood vessel. This leukocyte is going to roll over the surface of the blood vessel, and it is going to get adhered to the surface of the blood vessel, and it is going to ooze to the surface of the lining of the blood vessel and come out to the extracellular membrane. See, come out like this. That is what happens. So we can see this in margination, what leukocyte flow is peripheral to the endothelial surface of the inflamed site, and after that there is rolling of these leukocytes over the endothelium, and after that there is adhesion of this leukocyte of endothelium. And see this what rolling, that is after this margination, rolling happens like over the surface. That rolling is mediated by selectins and the adhesion, and then it gets adhered to the endothelium, and that is happening that is mediated by integrins. Remember it as like it is getting integrated to the endothelium. So it is integrins. And then what happens? There is diapedesis or transmigration of leukocytes. That is, they are going to migrate through the endothelium. How? By using PCAM1. By using PCAM1, it is going to migrate through the endothelium. And after that, what happens? This leukocyte migration happens and it reaches the site of the injury. That is called chemotaxis. So you have to remember this. This is very important. So what is the question? The question was, what helps in the rolling of leukocytes in the endothelial cell? That is, the answer is rolling is by selectins. Yes. Easy. Okay, and this is the last question of the day, that is question number 12. The question is, which of the following is an opsonin? Okay, opsonin. So what is an opsonin? Opsonin is something that get attached to the antigen. If this is an antigen, this opsonin, see, opsonin gets attached like this. So when it gets attached like this, it's like a flag. It hoists a flag that, yeah, I've got an antigen, macrophages, please come and take him. It's like that. Okay, it's like a alert, some kind of alert. That is what is opsonin is. So the question is, which of the following is an opsonin? The answer to this question is C3b. So C3b, here we have the pathways, classic pathway, MP lectin pathway and alternative pathway for what opsonization of an antigen, or a antigen means can be a bacteria, virus, or whatever. So what which is the opsonin, or which is the opsonin? That is a C3b. Okay, you can like learn this just as C3b. You don't have to like memorize the entire table. Just know that it is C3b. And what helps in the chemotaxis is C5a, and cell lysis is C5b. All right, so that is the end of discussion today, I think. Yeah, 20 questions are over. So yes, if you are having any doubts, you can contact me maybe through LearnElevate Instagram page, or I have a page, Pathoscope. You can contact it there. You can ask questions, we can discuss. Okay, and hope you understood what I was saying, and like you could relate and retain. That is very important. Please go through all these 20 questions and the topics I have discussed. Make it very accessible. Keep it in your phone and scroll through before you get inside the hall. Very important topics. This must not be left out. So if there is any doubt, please ping me. I'll get to you. So yes, we have 20 more questions remaining. We'll do it tomorrow. So, and hope to see you tomorrow there. Tomorrow also here. If you have any doubt, you can ask tomorrow also. The rest of the topics, that cardio and the rest of the renal, hepatopath, everything will cover tomorrow, and also the genetics, that will cover tomorrow. So hope you enjoy the session. Please revise. You're going to do very well. All my prayers are with you. So see you tomorrow, same time, 7 p.m. here. Okay, bye.